Welcome back to The Explainer. When things go wrong in the brain or the spinal cord, the clues aren't always screaming at you. They're subtle, they happen fast, and missing them, well, that can be absolutely catastrophic. Today, we're putting on our detective hats to decode the complex, high-stakes mechanics of the human neurological system.
Before we can handle a full-blown physiological crisis, we really need to understand what's actually on the line when the body's primary computer starts throwing error messages. The nervous system governs literally everything, from basic motor functions to your deepest survival instincts. So learning to decode these signals is pretty much the ultimate life-saving skill.
Here's our game plan for today. We'll start with the anatomy of the brain, move into diagnostic testing tools, tackle the neurological assessment, then focus on the unconscious client, and finally, wrap up with increased intracranial pressure.
All right, let's dive into Section 1, Anatomy of the Brain, the Command Center. We need to establish a solid baseline of how this system is structured.
Think of the brain as this highly secure, top-secret vault. Inside, you have these incredibly delicate neurons and synapses, all protected by tough layers of fibrous membrane called the meninges. And within that vault, you've got cerebrospinal fluid, or CSF, acting like a shock absorber. It constantly circulates to exchange nutrients and wash away waste. It's a beautifully engineered setup.
What's really fascinating here is how the outer gray layer, the cerebral cortex, delegates our conscious activities. It's so specific. The frontal lobe is handling your reasoning, morals, and speech. The parietal lobe, that's all about taste, pain, touch, and spatial awareness. Then you have the temporal lobe, running your auditory functions and Wernicke's area, while the occipital lobe processes visuals. And we can't forget the limbic system, that ancient core driving our emotions and learning.
And behind the scenes, there's this constant tug-of-war happening in the autonomic nervous system. It's a literal battle for balance. On one side, the sympathetic or adrenergic system is your fight-or-flight mode. It dilates your pupils, spikes your heart rate, and relaxes your bronchi to get you more oxygen. On the flip side, the parasympathetic or cholinergic system is all about rest and digest. It slows your pulse, constricts those pupils, and ramps up salivation.
Moving right along to Section 2, Diagnostic Testing Tools, let's open up the detective's toolkit and see how we peek under the hood.
So, a CT scan is fantastic for quickly spotting intracranial bleeding or structural shifts, but here's the catch. We often need to use contrast dye, and injecting that dye means we need strict screening. We've got to check for allergies to iodine, contrast dyes, or shellfish to avoid a severe reaction. But the real pro move here is assessing renal function and figuring out if the patient is taking metformin. Why? Because mixing iodinated contrast dye with metformin creates a massive risk for lactic acidosis.
Now, sometimes we actually need a physical sample of that cerebrospinal fluid. For a lumbar puncture, we first have the client empty their bladder. Then, we get them into a lateral recumbent position, knees pulled tight to the abdomen, chin tucked to the chest. Afterward, we monitor their vitals, watch for any CSF leakage, and keep them flat to prevent a nasty headache while the fluid replaces itself. But listen to this. If a patient has increased intracranial pressure, a lumbar puncture is absolutely contraindicated. Doing it could cause a fatal brain herniation.
Okay, on to Section 3, the neurological assessment. Let's call this the field interrogation.
What if you don't have a scanner handy, or you need an instant read on a deteriorating patient? This is where your bedside clinical skills absolutely shine. We use reflexes, posturing, and cranial nerve checks to map out exactly where the damage is happening. For instance, if you shine a light and see a unilateral dilated pupil, you're likely looking at compression of cranial nerve 3. Pinpoint pupils? That points straight to pontine damage or drug involvement. The body will tell you the whole story if you know how to read it.
You're probably familiar with the Glasgow-Coma scale. We use it to systematically score a patient across 3 categories: motor, verbal, and eye-opening responses. A perfect, fully awake score is 15. But the most important thing to remember here is the magic number 8. A score of 8 or lower tells us definitively that the patient is in a coma.
As things get worse, motor responses start reverting to primitive instincts. You might see decorticate or flexor posturing. This is when the client tightly flexes their arms right onto their chest while stiffly extending their legs. It's a massive red flag. It's the body's way of warning us that the cerebral cortex is non-functioning. But even more terrifying is decerebrate or extensor posturing. Instead of pulling inward, the client stiffly extends their arms outward and downward. This is an ominous, late-stage sign. It points directly to a brainstem lesion, meaning the damage has reached the absolute deepest, most vital parts of the command center.
Which brings us to Section 4, the unconscious client. We are entering the high-stakes crises now. Whether it's from blunt trauma, toxins, or a hemorrhage, an unconscious client is completely unarousable. They've lost those basic, primitive responses to pain that literally keep us alive. You'll see altered, erratic respirations and a scary decrease in basic cranial nerve activity. Things like the blink or gag reflexes just disappear.
So what's the game plan? Your absolute, non-negotiable priority is maintaining a patent airway. Why? Because poor breathing causes carbon dioxide to build up in the blood, and high CO2 actively dilates blood vessels in the brain, which dangerously spikes the pressure inside the skull. We place these clients in a semi-Fowler's position to help drainage, we maintain them NPO, monitor blood pressure and heart sounds, and we completely avoid the head-down Trendelenburg position.
And that leads perfectly into Section 5, Increased Intracranial Pressure, or ICP.
Think back to that vault analogy. The skull is made of bone. It cannot expand. So what happens when trauma or bleeding causes the pressure inside to relentlessly build? There's nowhere for it to go. It impedes circulation, it stops the absorption of cerebrospinal fluid, and eventually it crushes the brainstem.
You have to catch this early. And the absolute earliest, most sensitive indicator is any alteration in the level of consciousness. It might just look like mild confusion or restlessness at first, but if you miss it, it spirals into deadly late signs. Systolic blood pressure shoots up, pulse pressure widens, the heart rate dangerously slows down, and you start seeing seizures or a positive Babinski reflex. To fight increased ICP, we have to strictly control their environment. We elevate the head of the bed 30 to 40 degrees to let gravity do its thing. Keep the neck and hips totally straight. Flexing them cuts off drainage. We absolutely must prevent shivering because shivering burns up the brain's oxygen. And we tightly limit their fluid intake to 1,200 ml a day to keep further swelling down. As we wrap up this explainer, I want to leave you with a critical thought. We know that a simple, subtle shift in awareness is the very first domino to fall in a devastating neurological crisis. So, how closely will you monitor your next patient's level of consciousness? Because as clinical detectives, our job isn't just to react when the alarms go off. It's to spot the whispers before those alarms ever need to sound. Keep your eyes sharp, trust your bedside assessments, and I'll see you next time.